Hey everyone, and welcome. Let's dive right into today's explainer. We're going to map out a highly structured, dynamic, and visual breakdown of breast cancer management. With millions of people affected globally, understanding the exact path of care has literally never been more important. We aren't just reading off facts here. We're going to build a complete clinical roadmap, tracing the entire journey from the very first moments of diagnosis all the way through the highly specific, complex treatments required for advanced stage carcinoma. Whether you're reviewing this for your own clinical understanding or you're just looking for a clear, direct path through some pretty dense medical protocols, you are absolutely in the right place. Let's get to it. Our roadmap today covers 5 main stops. First, diagnosis and the triple assessment. Second, staging and key biomarkers. Third, managing in situ disease. Fourth, early invasive cancer. And finally, advanced management. All right, section 1, diagnosis and triple assessment. This is all about establishing our baseline. So we obviously have to establish how the disease is identified before we can even think about managing it, right? This sets the stage for all our clinical algorithms, because you really can't treat what you haven't properly defined. To get that precise definition, clinicians rely on what's known as the triple assessment. It's built on 3 distinct pillars. Step 1 is your thorough clinical history and physical exam. Step 2 utilizes imaging, primarily mammography and ultrasound. And Step 3 is pathology, which means getting a tissue sample, like a core biopsy. When you combine these 3 approaches, you're looking at a confident diagnosis in over 99.9% of cases. It's the absolute gold standard first step because it completely eliminates the guesswork. Now, looking at the imaging pillar, this is standardized using the BI-RAD scoring system. That stands for Breast Imaging, Reporting, and Data System. Notice how this categorizes findings to objectively dictate exactly what we do next. If a patient is a category 1 or 2, the probability of malignancy is essentially 0, meaning they just need routine screening. But as we move down the list to category 4, a suspicious abnormality, or category 5, which is highly suggestive with a 95% or greater chance of malignancy, well, a biopsy becomes absolutely critical at that point. To put that into perspective, when comparing a normal mammogram showing nice, healthy tissue structure with an abnormal scan, the difference is striking. That irregular, star-like shape, clinically known as a spiculated mass, is your textbook BIRADS5 lesion. When a radiologist spots those fine, angular margins, it's a massive red flag. That demands immediate pathological investigation. And for those suspicious masses, getting a definitive diagnosis requires tissue sampling. This is typically done using a 14-gauge, large-diameter core needle biopsy. The absolutely crucial thing here is that this procedure is done under local anesthesia and image guidance. It's aimed specifically at the solid part of the mass, intentionally avoiding any areas of cystic degeneration, to pull out a pristine tissue sample for the pathologist to examine. Moving on to section 2, staging and key biomarkers. This is where we really define the overall disease profile. Because breast cancer is definitely not a monolith, the modern AJCC 8th edition staging system goes way beyond just measuring tumor size or counting up lymph nodes. It deeply incorporates histological grade and vital multigene and biomarker testing. This powerfully refines a patient's prognosis. You'll also notice some specific modifiers in modern staging, like the prefix Y, which simply denotes a patient's status after receiving upfront or neoadjuvant therapy. And definitely pay attention to that last point, pathological complete response, or PCR. This is the ultimate goal in many cases. It means that literally 0 tumor cells remain in the breast or axillary nodes upon surgical excision. Now, to truly grasp modern oncology, you've got to understand this distinction. Prognostic biomarkers tell us about the overall cancer outcome, basically how aggressive the disease is, completely regardless of the treatment. Predictive biomarkers, on the other hand, are like a lock and key. They indicate the likely response to a specific targeted therapy. This is the precise logic oncologists use to select systemic therapies that are perfectly tailored to the individual. So what are the specific targets we're looking for? Well, we have the estrogen receptor, or ER, the progesterone receptor, or PR, the HER2/new growth factor receptor, and the K67 index, which essentially tells us how fast the cells are multiplying. Detailing these specific hormone receptors and proliferation indices is paramount. Why? Because their presence or their absence entirely dictates the medical oncology side of our treatment algorithm. For example, if a tumor is ER positive, anti-estrogen therapies are going to be a primary weapon, for sure. All right, section 3, managing in situ disease. Let's look at stage 0 protocols. With our baseline and staging clearly defined, let's dive into stage 0, or in situ disease, where the cancer has not breached the basement membrane. There's a critical difference in management here to keep in mind. Lobular carcinoma in situ, or LCIS, is treated primarily as a high-risk marker. Because it's often a diffuse risk across both breasts, it usually requires observation or chemoprevention, like tamoxifen, rather than immediate surgery. But look at ductal carcinoma in situ, or DCIS. DCIS is treated as a direct precursor to invasive cancer. It requires targeted surgical excision with a minimum 2 mm safe clear margin just to stop it from spreading invasively. So 2 stage 0 diseases, but 2 completely different protocols. Section 4, Treating Early Invasive Cancer. We're looking at stages I, IIA, and IIB here. In these early invasive stages, the primary goal of surgery is to comprehensively remove all disease in the breast and the axilla while achieving completely clear negative margins. That means absolutely no tumor cells are left on the inked, cut edge of the specimen. When it comes to that surgery, there's actually been a really significant trend toward de-escalation in modern medicine. Breast conservation surgery, or BCS, focuses on removing only the tumor with clear margins, which is then followed by mandatory radiotherapy. This is compared to a traditional mastectomy, which removes the entire breast tissue. What you should really take away from this is that clinical trials show conserving the breast with radiation yields the exact same local regional control and survival rates as a full mastectomy. Notice how surgical intervention is intelligently layered with adjuvant therapies. As we scan from stage 1 down to stage 2B, you can see a very clear progression. Stage 1 often involves a sentinel node biopsy and hormone therapy. But by the time we hit stage 2B, the algorithm escalates to include much more rigorous axillary staging, radiation, and multi-agent chemotherapy. The treatment perfectly mirrors the biological aggressiveness of the stage. And finally, Section 5, Advanced Breast Cancer Management, stages AAA, BBB, and IV. As the disease progresses to these more advanced stages, the clinical algorithm significantly shifts. We move away from a primarily local surgical focus and adopt a highly multimodal approach that heavily prioritizes systemic control. And this shift in treatment requires a shift in how we actually visualize the disease. Consider the contrast between the localized imaging of early stages, where we use mammograms and ultrasounds to check the local breast and axilla, and the absolute necessity of PET scans in advanced cases. For those advanced stages, we have to conduct full systemic staging to hunt for distant metastases. And this is exactly what we're looking for in advanced staging. When reviewing a transverse view of a PET scan, we're checking for clear metabolic hotspots. You can see that bright orange and yellow radiopharmaceutical uptake. These hotspots indicate regional or distant disease spread, which fundamentally alters the entire survival strategy. Because of that spread, for large or inflammatory advanced cancers, we often just flip the script entirely. Step 1 becomes neoadjuvant chemotherapy. This is administered before surgery to shrink the tumor and treat any microscopic disease hiding in the bloodstream. Once the tumor responds, step 2 is surgical resection, frequently a modified radical mastectomy and axillary dissection. Finally, step 3 is adjuvant radiation therapy to sweep the chest wall and lymph node basins. This results in a truly robust, multimodal defense. To bring this all together into a cohesive roadmap, consider this incredible fact. None of these complex treatment pathways happen in isolation. Modern management is driven by a highly collaborative, multidisciplinary team. Surgeons, radiologists, pathologists, and medical oncologists literally sit at the same table, working in concert to tailor these precise algorithms to each individual patient's unique biology. It's a real team effort. Which brings us to a final thought. As we look at this incredible clinical roadmap, from those initial biopsies all the way to advanced multimodal treatments, we're seeing a really clear trend. As our predictive biomarkers become sharper and we continue to de-escalate surgical interventions, will the ultimate management of breast cancer one day rely entirely on targeted cellular therapies rather than the scalpel? It's a fascinating question, and it gives us an inspiring look into the future of medical advancement. Thank you so much for walking through this explainer with me. Keep your focus sharp, and I will catch you next time.